Thank you, everyone, for coming live, and for those of you who are going to watch the recording of our weekly seminar series for the Center for Healthcare Policy and Research. I and our Associate Director of the Center, Dr. Jeff Hotch, sort of lead this seminar series, and we have a lot of different folks who join us from a graduate school seminar to continuing medical education to people who are just really interested in the topic for that day and sort of pop in and learn with us. So thank you all for being here. Today, we are extremely fortunate to have an expert from our own campus coming and joining us to speak about her research and sort of the impact that of the project. I'm guessing multiple projects that she's working on. Dr. Aubyn Stahmer is a professor in psychiatry and behavioral sciences. She is also the director of our Mind Institute here, which is the Center for Excellence in Developmental Disabilities. She has so many large center grants and other amazing research projects in the implementation science and community spaces focused on autism and supporting autistic families and community members in a variety of ways. Too many for me to name, Aubyn, but so many amazing accolades. And so for NIH funding, other types of funding mechanisms. And so we are just so honored to have you join us today. Thank you for coming.
Oh, thank you for having me. All those things just mean I'm old. That's okay. So I'm going to try to share my screen and see how that goes as a way
Great.
to start. I'm really excited to talk with you all today. Let's see how that works. Can you see
Looks
the,
great.
the slide? Fantastic. So I'm going to talk in some detail about a particular implementation project and how we got there, and because we have a lot of data and thoughts. And then I'm hoping I have time at the end to share some of the challenges of large implementation projects and some of the ways we've thought about those moving forward. So you can all solve those by the end of the hour. Um, so our acknowledgments for this is this project was funded by an NIMH grant, two NIMH collaborative R01s. We don't have any other disclosures because, just the federal government. I'm going to talk today about two linked hybrid type 3 trials. So in implementation, that means we're really looking at implementation strategies and not particular evidence-based interventions. But the trials that are linked, one is looking at a particular evidence-based practice in schools called classroom pivotal response teaching, and that's the R01 I led. And my partner in crime is Dr. Lauren Berkman-Frazee at UC San Diego, and she was looking at an intervention called Aim High in mental health programs. And I'll talk a little bit about the interventions, but not very much because I really want to focus on the implementation. And then those pictures are just some examples of the many, many, many people it took to do this really complicated project. So I just want to thank all of them, and also Dr. Anna Lau, who led our UCLA site. So just in case many of you are not familiar with autism, we now note that 1 in 36 children with autism exist in our country, and more than that in California, because we're pretty good at identification here. And like other conditions that we talk about in this meeting and others, we have evidence-based practices, especially in the younger age groups, that work well for autism, improve outcomes. But their uptake in public service systems is very inconsistent. And we really have focused in the long term on provider training and how we can teach providers to use new practices. And that's really repeatedly sort of failed in getting those practices into high quality use. So that's a problem that we've been trying to really think through. And the context of the structure of services for autistic children, again, similar to other mental health and medical conditions. We have workforce shortages, we have very limited resources in these public systems, high staff turnover, and all of that makes a difference for implementing evidence-based interventions. But it's important because we know that these interventions can lead to changes in children's communication, their behavioral integration, inclusion, and quality of life. So, because you all are implementation scientists, I'm going to share the framework we used. Just to orient you, we use the exploration, preparation, implementation, sustainment framework developed by Greg Ahrens and colleagues in San Diego. I think you could use any one of the many frameworks. You don't need to make a new one, but this is the one we used. It has this circle of timing around the outside that really is ongoing in terms of implementation, as well as thinking about the types of factors that might affect implementation at each of these times. So we'll talk about outer context factors that might be for us, autism policy, what interventions are funded, what autistic people think about particular interventions. The inner context is really the agency level, and I'll talk most about that today. And then the innovation factors, which is how the evidence-based practice fits within a system, how complicated it is, things like that. I'll talk a little about that. And then bridging factors, which would be things like community partnerships. So just a word on community partnerships. All of the work I'm going to talk to you about today from the very beginning has been done in collaboration with community. We think that's a very important part of our implementation work and don't think we could do it at all without that. So community partners have worked with us to develop each of our projects, adapt the interventions, adapt both the behavior intervention as well as the implementation strategies. And we really think that has increased the impact of this work, our ability to even do this work. And we think the rigor is still high. So autism's community context. Autistic individuals are served across service systems. The two service systems I will talk about today are mental health, both outpatient and school-based clinics serving autistic children. If you aren't familiar with autism, about 70% of autistic individuals also have a co-occurring mental health condition, often disruptive behavior disorders, anxiety, or depression. So they're seen in mental health clinics, but often that primary condition is what they're being seen for with limited even identification of autism. And then the education system, which serves almost all autistic children, where we are working with teachers who have more experience with autism but need support for using evidence-based interventions. So back to the beginning on how we got here. We started with two independent hybrid type 1 trials. So these were trials looking at adapted evidence-based interventions that were either adapted or developed in community partnership. I'm not going to happy to talk about how we did that, but that will not get us through in the time we have today. But Lauren and I were each doing separate trials as part of actually Career Development Awards. So it was a long time ago, adapting and developing these interventions for different systems. So classroom pivotal response teaching is an adaptation of a parent coaching intervention that teachers were trying to use in their classrooms and adapting in particular ways. So we worked with them using observation and discussion and back to the lab trials to adapt it for group setting. And for the AIM High intervention, it was really developed for providers who had limited autism experience. And it's a sort of a structural way to adapt hour-long sessions in mental health context to support autistic individuals. Also developed collaboratively and based on needs assessment with these agencies. And so these were wrapping up around the same time. And interestingly, we found very, very similar findings in these two different service systems with these two different EBIs. So both improved child outcomes, yay. And in both cases, providers were able to use the strategies with fidelity in their systems. They found them feasible, they liked them. This was important because fidelity to the model or how well they were using the strategies was associated with how well the kids did. So the challenge we had, though, that the fidelity was really variable. So we had a lot of people using things well, and then some people using it not so well, and some people sometimes using it well and sometimes not. So we really wanted to think about how we could fix that in our in our new trial and what kind of supports people would need. Okay, so I did put that in. I'm going to skip it. Okay, so then we took our data across both those projects, and we got so lucky because they were hybrid trials. We had some implementation data, and we had this lovely interview data that an outside implementation scientist did with our teams every, I think, 6 months about how implementation was going and what we were seeing. So we could look back at that and think about what went well, what didn't go well, plus, other implementation data we have. So I highly recommend putting that into your effectiveness trials. And two things that we found to be really important. One was leadership support. So if leaders in the school or the mental health clinic help people free time, got a sub, reduce caseload so they could attend training, allowed people to do it on work time. There were some that didn't. They had to do it after school or after work, provided supports, made sure there were enough manuals. If materials were needed, they got those, and we're kind of really into the process. That made a difference at how consistent fidelity was for providers. The other thing may not be shocking, but it's provider attitudes and motivation to the training, right? And so, how motivated were they? And this is really relatively subjective in terms of our trainers could often predict at the second meeting whether a provider was going to be certified in the model or not. And so, thinking about that and what we might do to support them, and their ability to sort of handle challenges that come up, which often happen in a public service system where, their co-teacher is out or things like that. So we wanted to look at these two areas and test implementation strategies that might help improve fidelity and provider engagement and training. So back to our model, these are inner context factors that might help or hinder use of an evidence-based intervention. So we looked at provider attitudes toward evidence-based interventions, leadership support, and within that leadership, also the implementation climate. So I'm just going to talk a little bit about what each of these concepts mean before I go into the study. So when we're talking about implementation leadership and teaching special education directors, mental health clinic leaders to be better leaders related to implementation of new practices, anything, we're asking them to be proactive. How much do you think about what you're going to need to do? What are you going to do when someone goes on maternity leave? How are you going to fit this in with other initiatives you're doing? Knowledgeable. So how much do you know about this evidence-based practice? We're not expecting a leader to be able to implement something with fidelity, but maybe they want to know how long the training takes or what materials are needed, things like that. How supportive are they of people who are doing this practice? It can be really challenging. So are they providing any kind of supports related to when you can do this practice, things like that? And then how perseverant are they when challenges happen, and challenges will happen? You'll see they will come. So is that leader sort of have the capacity and really the motivation for this innovation to keep going and problem solve around that? Then implementation climate is really more about the whole feeling of that institution, school, clinic, or whatever organization you're working in. How much, as a worker in that setting, do I feel like if we're told to do a new innovation or a new practice, is my organization focusing on it? Are they talking about it in staff meetings? Do we get, screensavers at the health system about it? How much educational support are they providing? So similar to the leadership, are they doing that? Am I recognized for using a new practice? Do I get a shout out? Do I get rewarded? These concepts come from business, so reward is less frequent for our guys, but their teachers are pretty happy with a t-shirt or a Starbucks card. So does someone recognizing what I'm doing and thinking it's important? And then when my leadership is selecting people or when our teams are hiring new people, are they thinking about whether they know the practices we're supposed to be using or whether they're open to learning them? So those are the kinds of questions we ask about implementation climate when we're measuring that. And then we also look at how providers feel about evidence-based practice kind of generally, right? Not necessarily this particular practice, but we talk to them about that as well. Are they more likely to use a practice if it's appealing to them? Are they more likely to use it if it's required and not likely to use it if it's not required? There's some scales that tell us how open they are to learning new things and how willing they are to do new things if it doesn't fit with what they're currently doing. And you can imagine some of this is really different based on whether you're a first year teacher or a 21st year teacher, and what the climate is in your program as well. So those are the things we were thinking about when we developed this trial. And so we had our evidence-based practices. We thought were pretty good training models for these, both practices. And so everybody in this study was trained in one practice or the other, depending on if you were a mental health provider, you got AIM High, teachers, speech pathologists, people working with kids in classrooms got CPRT. So everybody's getting that. And then what we're testing here are two implementation strategies, and I'll talk a little bit about what they are. But one is the Teams Leadership Institute, which is a leader level strategy where we're teaching those implementation, leadership, and climate. And the second is we're calling it TIPS. The words really are just to make it say TIPS, but it's a motivational intervention for providers done by our trainers. And then our goal was to see which of those implementation strategies led to better provider outcomes related to certification in the evidence-based intervention and fidelity to the intervention. And secondarily, we looked at child outcomes. These were done by parent questionnaire. So the parents really weren't too involved in the intervention, more in the mental health than the school. And we asked about behavioral characteristics that might change. So pretty distal, but it wasn't our main focus. So that's kind of what we were looking at. So let me tell you a little bit about the implementation strategies. The Teams Leadership Institute was adapted from a larger leadership intervention called Leadership and Organizational Change for Implementation, or LOCI. And we shortened it to fit our public systems and their limited time. But we started with an assessment of implementation climate and leadership. So those concepts I just talked to you about, a lot providers and leaders in the program or district filled out these surveys. We got the data from at least 5 providers in that program, so it would be anonymous, and use that to develop goals. So we did training and implementation, climate and leadership and what they were, a little bit of information about the evidence-based practice and why it's important, and then use the data from their own district or program to develop goals in this initial workshop. Then we followed up with them about twice a month, depending. We scheduled twice a month for like 15 to 30 minutes to check in on goals, problem solve, work with them to make sure that their providers had the support they needed, that our team was doing what we needed. We did a second assessment at about 4 months in, and then reassessed goals and thought about sustainment. And so this is happening at the same time the providers are getting their EBI training. It takes about 6 months, and then there's a graduation for providers and leaders together. So just as an example, a leader would get some sheets like this that showed this is educational support for use of evidence-based practices. And you can see the leader self-rates them that they do this to a moderate extent, and the providers are saying maybe a slight extent. Some ratings were good, some ratings were poor, some leaders rated themselves really high, and the providers didn't, and we kind of thought through why that might be, and then set goals based on these data. So some examples of the kinds of goals that went into a plan around implementation climate, often it was around recognition. So we're going to highlight the efforts of supervisors using this strategy. We did a lot of working with the special education department to let teachers' principals know what they were doing and why, because there was often a disconnect there. Providing support with materials, making sure staff had time to practice the strategies when they needed to. Around leadership, and examples of goals in the proactive area would be check in with teachers every once in a while about challenges they're having with this. Sometimes that would lead to some support for practicing while somebody else took the rest of the class. Support with management of clinical productivity for the mental health providers. maybe attending a workshop to get a little more knowledgeable about the program or understanding the concepts of what teachers were learning. So those were just examples of goals someone might have. And typically they had 1 to 2 goals in each area. That was the leadership intervention. The TIPS intervention, so an individual provider strategy for training, was really based on motivational interviewing. So we worked with a motivational interviewing expert to adapt our training to support teachers going through training. So our trainers were trained in this. The trainers trained in motivational interviewing could not train groups of teachers or providers that were not randomized to that condition, because I guess you can't unlearn that. So that was we made sure, and we checked fidelity and all of those things. But they got a pre-training call where they learned about what was going to happen, identified any potential challenges, kind of problem solved that with proactive planning and feedback at each training session. We had a workshop and multiple consultations. So each one included some quick check-ins. They got motivational reminders via text or email between sessions, and then we had some rescue strategies for folks who did not seem as engaged. So here's what we did. We had the Teams Leadership Institute at the program or district level, and then we were looking at the provider child level at TIPS. And what our hypothesis was that Teams Leadership Institute would affect the mechanisms of implementation, leadership, and climate, as well as the use of these specific implementation support strategies, which we measured as a checklist. We thought that TIPS would improve provider attitudes and motivation, and that together they would improve our outcomes that we talked about. So we did this in the context of 4 cohorts. We randomized programs or districts and enrolled them, randomized them to either receive our gold standard training that we always did, provider enhanced training, so that's our regular training with the TIPS trainers, leader training, so our gold standard training plus TLI, or the whole thing. They got the enhanced training plus leadership, because we thought we could then kind of decompartmentalize which one was working for what. Everybody, again, got the EBI training. It was just a matter of which implementation strategies they received. And you can see we did have a challenge in cohort 3 with COVID, so I'll talk a little bit about that. But we enrolled across both studies, and it was pretty even across both studies, 95 leaders in 65 different programs. 387 providers, and they enrolled with a child or family. So 385 families ended up completing. So just to talk about COVID, because who doesn't? Cohorts 1 and 2 were about 63% of our therapists and 55% of our teachers participated before we thought about things like COVID in the before times. Our cohort 3, which was a very large cohort, was disrupted. So even the mental health providers were usually working on a school year calendar because they're seeing kids usually in a school year format as well. So you can imagine that a closure in March was a challenge for our 6 months of training that probably started in the fall, and everybody kind of went home. But we have addressed that in our analyses, and we took some measures to fix it, which I can talk about at the end if you want. And then we did another COVID or post-COVID cohort, which we still felt was pretty different from our first 2 cohorts. It started the next school year. And so during COVID, people were really distanced, and you can imagine that for teaching autistic children, that felt really different than doing it in the classroom. But we adapted strategies and continued to coach some places. A couple places didn't finish and started again, but most of them were close. And then after COVID, we had masking, we had some programs in person, some programs still distance. So all of this is accounted for in our analyses. So we measured our implementation outcomes, so certification, which was really our coaches, coding fidelity for paperwork and goal development and use of the strategies. So it's a yes or a no. I'm certified or I'm not certified. And then our fidelity measures were coded by naive observers using rating strategies. And so those are continuous variables. So we have a little more variability. Then we looked at clinical outcomes on surveys, clinical surveys rated by parents. And then we looked at all those mechanisms that I talked about, as well as attendance and training engagement. And here's what we found. Basically, we had significant results for TLI over time affecting average provider fidelity and child outcomes. Honestly, we were pretty excited to get child outcomes from a leader intervention and made us feel like leaders are pretty important in this process. So, as an easier way to look at it, the team's leadership institute was associated with higher provider fidelity and better child outcomes, both of those outcomes. We did not see a change in certification rates. We did not see tips associated with any outcomes at all. And if we have time at the end, I'm happy to talk about why that might be. I think there are multiple reasons that may or may not, we may or not want to throw out motivational interviewing. And then we also looked at whether we engage those mechanisms. And so what we found is that the Team's Leadership Institute really engaged that proximal mechanism of when providers were asking them, are they using these implementation support strategies, which were similar to those goals you saw me talk about. We did not see significant differences in implementation leadership or climate. So we did not engage those mechanisms as measured by those tools. And then TIPS did not engage any of the provider motivation mechanisms. We did have a weird interaction that I'm not quite sure how we explained. So at the end, if you want to talk through this, we're happy to. But if for the groups that got both the leadership intervention and the motivational intervention, we did see engagement of implementation climate, so better implementation climate in those agencies and better provider motivation, which seemed a little odd. But it wasn't, it was only in relationship to the tips only group. So it seemed like when you look at the data that something about the way we were doing the motivational interviewing made the providers really sensitive to when their leaders weren't supporting them, like because they're thinking about the challenges and things like that. It seemed that TLI was protective against that more so than launching things forward like it did in the other groups. So some examples of the strategies that we saw them using more of. This is leader report of those implementation support strategies. The provider report looks pretty similar. So examples are like the EBI is included in individual meetings with my manager and supervisor. We talk about it. We have a designated time to talk about training and what I need. It's being rewarded. People are recognizing success with this. And they're linking that with organizational priorities and contracts. So an example would be in schools, there are a lot of schools who are implementing universal design for learning, and the CPRT strategies have some overlap with those. So we built a crosswalk for people so they could do that together because the leaders asked for that. So those are some examples of the strategies leaders were using better after some training because then they knew to use it. And then in our qualitative data, what we saw was that the leaders liked the structure and accountability of doing the leadership intervention. It was fairly low intensity. They had these 15 to 30-minute check-ins, but knowing they were going to follow up and think about the progress and the goals kept them on track. They liked being able to bring their team on board and have them on the same page. They felt it maintained motivation and focus on getting those practices into use. So this is sort of a summary that I already talked about, but I want to think about, this is our next step, the role of team members in the Team's Leadership Institute. So we adapted this from a model where mid-level leaders were trained in these strategies, plus some other leadership strategies at an individual level. Individual coaching, with some work with a higher level leader, but mostly was very individual. What we found in children's mental health and schools, and maybe because autism is such a multifaceted condition that needs so a multidisciplinary team, there were teams almost all the time. We rarely had one leader go through training. It was typically more like 3 to 6 leaders. And it wasn't something we had planned for or not planned for. It just really happened. And so we've really been thinking more about the role of additional team members in TLI. We did a lot of distance training, even right before the pandemic, but then after the pandemic. And so that seemed to be even more team-based, and they needed the IT person. And, now people are uploading videos. We're not taking cameras out to their schools and things. So we've been thinking a lot about that, and I'm happy to talk about some work we've done around that. So we're really testing, just kind of wrapping up a study where we're testing a team enhanced version of TLI, and also working on some projects to think about mechanisms. So I'll share those. But in general, we were super excited that a leader level strategy had such high impact, improving both fidelity and child outcomes in both settings for both EBIs. We did not find that the provider strategy improved outcomes, potentially because of the dosage, because of us trying to make things pretty similar across groups. And we didn't find the strategies to be additive either. So I'm going to talk a little bit about some challenges and strategies that will hopefully lead to some discussion around these areas. Because we had a lot of stuff happening. If there are questions, are there questions now about the study before I tell you all our challenges?
Not yet. Not yet.
Okay. Okay. So really dynamic inner and outer context, right? The context is going to change between the application and the start of a project. So one of the things that changed in California in the middle of this project was how children's mental health services are funded. And that was a huge, I don't want to say a blow, but it made it different in how we had to recruit. How autistic children could be seen or not seen in mental health clinics also changed. And so that was a challenge. And so I think expecting that the context will change during the study period. I mean, we were not expecting a global pandemic. Nobody was. And so I think things not that big, hopefully won't happen again, but things happen. Our initial goal was to really enroll programs at the same time and start them in these cohorts at the same time so that we could do things together. That is not a thing that happens. And even if they provided a level of support, we're part of our team that developed the grant, maybe the leadership changes, or maybe teachers leave, or maybe, different things happen that makes it so they can't always do what they thought they wanted to do. And the turnovers of leaders and providers is challenging, especially when they move from program to program. So they might have been in one condition in your study, and then they move to another program that's in a different condition in your study. And so thinking about how to manage that was challenging. Kids move from one classroom to another, and they're in the study, and their teacher is or isn't. So things like that are fun. They're fun for your statistician. So we really work hard at keeping communication with our partners going to understand what their stresses are and what we might need to adapt as we go. We, in this project, and I have a new one now where we have changed the design multiple times in order to fit with recruitment. So in this particular study, we were having challenges. Our goal was to recruit from San Diego, Los Angeles, and Sacramento. We were having challenges getting enough people, but lots of more distant sites that wanted to participate. So we needed to change the design and allow for distance sites and figure out a plan for how to do that training well, is an example. Planning for waves of enrollment and rolling recruitment, I think, is just key in these kinds of studies. And then really along the way, making sure you're talking to your statistician a lot about how to identify and manage these challenges so that when it comes time to do the data analysis later, they understand what has been happening. We talked to our program officer a lot about these changes and challenges, so that she was aware that we were still going to be able to meet the goals of the study. And she had some really great feedback about it. This is one of the biggest challenges, I think, and why we needed to do linked R01s was because of power when we're looking at organization level strategies. And then we have, what level are we going to randomize at, and how are our data structures nested? And so it's really different. Different school districts are set up in different ways. The role, for example, of the principal as a leader is at the school is very different in some districts for the special education teacher than in others. It's just really variable. So who was on the leadership team was a huge challenge to even try to figure out. There were a lot of differences. In California, we don't only have school districts, but we have special education local plan areas that oversee school districts. And sometimes they were interested in this training. And how does that fit in? Some of the mental health programs that we enrolled had multiple sites. And do we randomize those together or separately? So how does that all work? And doing these multiple sometimes, let me think about what I'm trying to say. The burden and complexity for managing two conditions. So sometimes mental health services for autistic children are done in schools. So schools have clinicians that are pulling kids out and doing mental health services. And so some districts were like, yeah, we want both. We want to participate in both studies. We have different leadership teams for both, different professionals for both, no problem. It's challenging, though, for them to manage both things and the demands that come with being in a research project, just generally. And then risk of contamination if you don't randomize at the right level. So it would be great if we could have randomized teachers or clinicians, for example, because you get a lot more variability and power. But if they're in the same program, maybe they're going to talk to each other. And then also, if you're doing leader training, what level are you training the leaders at? At the school level, at the district level? We were doing it at the district level, so all the schools in that district need to be randomized to one place. Whereas in the mental health system, we were training leaders at the clinic level. So there are different things to think about as you're thinking about your nesting. And so we did a lot of work with providers and administrators in the beginning to think about how our nesting would go and how, when people didn't fit our nesting, how we would adjust that and how we would manage that in our data analyses. Even though, for example, district and program might not be the same in our analysis as district in the eyes of the district, we wanted to make sure it was clear for our data analyses. And this came up for us around charter schools and how they wanted to participate and how their districts are sorted. So when new programs in the same organization wanted to join, we had to think about how we would randomize them. And then really thinking about our study IDs and data, so that when participants moved, we could figure out if we were going to keep them in the study or if that was contaminated or how that would work, because it was an intent to treat design. Leader engagement is essential, regardless of whether they were in the leadership condition. We were enrolling districts and programs, so the leaders really needed to be enough engaged that they would give us access to their providers. And so that was really important. And that's been important in our new project as well. Am I running out of time, Courtney? And then thinking about, we yoked participation between our providers and the kids, and that was really important to get the providers engaged and moving quickly. And then thinking about confidentiality is important, related to working with a leader to help providers get kids enrolled and participate, but also not going back to the provider, not delivering any information to a leader that would be evaluative of a provider. And so this last one is really just think about how much time it takes and how you do your tracking. So let me just think about what we've learned from this is that leadership investment is really important. We need more research on how to scale this because now we have an implementation strategy that's really great, but how does that get delivered in real life and who pays for that? How do we adapt it for different systems and different evidence-based interventions? So we're thinking about that now. And then it's been really interesting. Like this is to me is a huge implementation study throughout the state of California. And our communications people just don't care that much about what leaders do. So thinking about how we can message the importance of implementation policies and strategies. And so we have two new projects. The InStep Center at UC San Diego, we have been testing this team intervention to build team cohesion and effectiveness in the TLI model. So I should have some data on that soon. We're excited about that. And then we have a new autism research consortium in behavioral health where we are compiling data from multiple studies who are using organization level interventions to try to see if we can figure out what mechanisms they are engaging when we have a little more power. So lots of thank yous to all of our participants, our systems partners, all the people. And I'm happy to talk more about any of those things. And I will stop sharing my screen.
And I was not rushing you. I was just eating my lunch. So I was done.
Okay, good. Just wanted to make sure we
So,
have time.
no, you have a good amount of time, about 15 minutes at least, to answer questions. So please do write in questions on the chat or raise your hand in the Zoom feature. I promise I will call on you. I'm looking for it. Um, Jeff, do you want to start us off?
Oh, Jeff, you're so nice.
Oh, thank you. Really appreciate the talk. Thank you for making time to talk to us about the studies. You make it seem so easy. And I imagine there's a lot of behind the scenes stuff going on. And my question was when you talked about motivational interviewing, I got the feeling that there might be some other stories behind the stories.
Mhm.
And could you share with us those as well as how you were able to realize that maybe what you were seeing had deeper context or meaning, and how, as researchers, we know when to look a little deeper?
Yeah. Um, so for the motivational interviewing, we had developed these trainings using adult learning. We looked at adult learning theory and research around the trainings we developed. So some of the strategies that are unique to motivational interviewing or motivation that are motivational, not motivational interviewing, but just motivational, were already embedded in our training. So we think that's a challenge for trying to add something new. Um, Probably, especially COVID and post-COVID, people were pretty motivated to participate, to do it at all, because everybody was relatively stressed. And then we had to fit the motivational interviewing in the same amount of time when we were doing the other training, pretty much, because we didn't want it to just be time with your coach, right? And so I think that was a challenge, is it really, I don't think the dosage was high enough. Even though the fidelity was really different, I just don't think it was enough to make a difference in their motivation. And for whatever reason, I do think that we were actually calling out challenges with them in a way that we weren't before, that I'm not sure was helpful. And then in terms of how we figured, like, are you meaning how we figured that out or how we figured out what? Yeah. Um, we talk a lot about process in our team meetings and with our trainers, and especially when we're doing rescue strategies. But for this one, the data were really clear. And so then going back and thinking about why this might have happened. Thanks, Jeff.
Great question, Jeff. Stephen, you're muted.
Thank you for the very nice presentation. You mentioned that you were in contact a lot with your program officer at NIH, which is interesting. But I had a question: how did you manage the IRB for this? In my limited experience, IRBs are not really equipped for sort of pragmatic trials, and particularly implementation trials where things change a lot.
We made a
Uh,
lot of adaptations to our IRB. So we're all UC campuses. So we relied on one IRB. For this particular one, we started with UCSD, and UCLA and Davis relied on that IRB. So that was super helpful, not to have to go through multiple. And then I can't even imagine how many adaptations we made, but it was just a lot of amendments to the IRB. Sometimes easy and sometimes not so easy. But most of the things were more um, like design side stuff. But we did, we had to change, we had to really think about, had lock boxes and cameras in the beginning to do the video recording for fidelity. And then post pandemic, we had to think about how's someone going to record that and upload it and the security of that. So it was just a lot of amendments, and they were, I mean, sometimes it took some discussion, but they were pretty good about it, I have to say. I think the biggest challenge we've had is whether, like, are the leaders participants or not participants, and how that works. In this case, they were. Is our community advisory board a research participant or an investigator? Those kinds of questions have been harder.
Thank you very much. Thank you.
I had one type of logistical question like that and then one bigger question. So I'm going to chime in, but please do keep raising your hand. I promise I will get you in. When you say linked R01s, can you talk more administratively
Yeah.
about that for everyone to know?
Yeah, I don't know if it's still a thing, but you can submit basically the same R01 together with some different focus. You might even not need a different focus, but we had, one was schools and one was mental health. And then basically the text was exactly the same for both of them. And the argument was we could not get the power to test these org level strategies without combining, and that it also gave us the ability to look in two different systems at two different EBIs. So that was our argument. Our program officer initially said that's way too much money. That is never going to get funded. And it was funded on the first time through, which is shocking. We have it framed, the pink sheet's framed. So yeah, I don't, and God knows if that's still a thing, but it was a way to really get enough power. We couldn't figure out another way to get enough power.
So interesting. I've also heard of people getting that pre-approval for a much larger budget. And so it seems like that
Which
could
I
be.
don't think you need anymore. I think you're allowed to have a larger budget without pre-approval.
Well, maybe that will be something you'll do in the
Yeah.
future.
Yeah.
Okay, because that's great. I was looking and I don't know if they do the linked R ones, but just I think the lesson is don't stop just because the budget would be limiting you at NIH or the sample set. You know what I mean? Be creative and think of other options to submit your idea, because this is an amazing project and it wouldn't have happened even if your program officer said no, you still went forward and didn't take a no for an answer. So that's one logistical question that's sort of related to the IRB. And I guess is also logistical, but I do think it's really about how you did the study. Can you talk a little bit about how you recruited the districts and like how people heard about your study, and how you seem like you're really almost like a teacher yourself, like an insider into you know what I mean? So maybe you could talk through how you worked on those parts and how you think that
Yeah.
affected who ended up in the study.
Yeah, so interesting. So I was in San Diego before I came here, and so that was our easiest place to recruit, because the AIM High was developed there too. So we had relationships with schools. They'd been on our community collaboratives. Makes it so much easier. So my really lucky thing when I came here is that our university center was one of the people who started this statewide training collaborative in autism evidence-based practices. And so there are 400 teachers enrolled in that program. So that, because I could get into that partnership well, we did things like give talks about other stuff they were interested in and lots of things that we could do for them. And then we had access to the SELPA directors for the entire state. We got to give a presentation there and to have them really talk about how this could be important and helpful versus us just cold calling people, although we did that too. Lots of emails and cold calls. Now we would probably use social media more than we did then. But a lot of it was word of mouth for different programs, and oftentimes really checking back the next year. Well, you thought maybe this year you'd want to do it, but you didn't. So next year. And then when we kind of exhausted our areas, going out to more rural areas that just don't have access to any training. And that was helpful. And the fact that we were providing training for free that would lead to certification was really helpful so that they felt like they were getting something out of it.
I love that. Like principles of community-based research, but with your stakeholders and your districts and you know what I mean? Like thinking through what their priorities were, how you could, I think that question comes up a lot, right? What are they looking for? How can we help them give talks or access experts or whatever other, in addition to the study activities. So it's like the master class, Aubyn. And then that last question related to that is, so this they weren't compensated then in terms like how did you pay or compensate? It's a lot of time to do
Yeah.
15-minute coaching. And how did that whole piece work?
Just regular gift cards. Honestly, the leaders were ready to do it. They wanted the training. And so that was an
That was really the
advantage. They
hook.
really
Yeah.
wanted the training. And the training was of no, the cost of the training was the time. I think we could have had better recruitment if we had more money for training to pay them, but we just didn't have that. And I would say, so like if a school, like I had a call from a SELPA that participated in our study 3 years ago to give a talk, and I will say yes every single time because they did that. Or someone from my team will. But yeah, it really was very limited. And I always say when we're doing implementation studies, our research stuff gets in the way because it's such a pain. So we did pay every video they uploaded, every survey they did.
Yeah. And my sciencey question related to that is, do you think that was part of the reason why the leadership was so effective was the people were very engaged, with like relatively small incentives already ready and wanting, do you think that had anything when as you're
It's,
doing your second study and
yeah,
spreading it, is that a piece of it, the readiness of the leaders who ended up in the sample?
possibly. It's funny because they want to do it, but sometimes they're not that engaged. And sometimes the best leaders just are so busy, they're scattered, it doesn't have time. So yeah, that is also a challenge. I say we tried to do these coaching calls, we didn't always get to do it. And then sometimes the leaders really want it and the teachers don't, or the providers don't. Like there's that disconnect, or vice versa. Sometimes the providers are like, please, 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 and the leaders will be like, fine. So I think it does make a difference, but we haven't measured that well. And I think the last thing I will say about doing a giant study like this logistically is you have to have a partner who's really good and you can trust and you get along with, because that is key.
You mean as in the co-PI piece of this?
Yes,
Yeah, that's what
yes,
I thought you meant.
yeah,
That, yeah, it's a ton of work. And if you had, I mean, it's two linked R1, so obviously two huge projects, and not to do this with another person who's not committed
right.
to the level of detail and this. I think you did a nice job of, there's so much positives you get. There's a slog of like making sure people attend, but there's also all these positive pieces that come from you come to somebody in one year and you come back to them in another year in this long-term relationship. I just think that's a lovely example, especially for early stage researchers who feel like they're not going to write a huge linked R01 to get started, but you can start small, you can get to know people, you can figure out what you can offer them. And
This
your
started with a
research.
K,
Yeah,
started with two Ks that
yeah,
weren't linked at all, right? And so I think that's a really important point, Courtney.
that's great. We have time for one final question. Does anybody else have a question for Dr. Stahmer? Making sure there's nothing in the chat. Um, I just think, yeah, I love all your models. I guess, is there any other lasting piece of advice that you'd want to leave people in our Health Services Research Center if they wanted to dip their toe into the implementation science or implementation research domain that you didn't get a chance to talk as much about today, Aubyn, or anything you wanted to expand on before we end?
I guess it's just really fun. Like I really loved the partnership part. It takes a lot of time and it's hard, but I do think UC Davis is understanding it and getting more committed to it. And so I am hopeful that we will be a nice model for figuring out how that fits into all of our academic credits and how we can pay our partners well. And so I guess I'm really happy to be at this university for that and to have your center to help us, because it really is fun work. I mean, going into it, we were like, there's a pandemic that just split the study. We're not going to find anything, but we trained 400 people no matter what, right? So it's really fun. I would encourage anyone to give it a go.
I love it. I would also encourage and just think about, I think all the things you said apply to clinics, apply to other organizations. I mean, you can see here how that's really the beauty of it. It can be for any group that you're interested in terms of changing practice or changing processes, policies. Um, yeah, yours is really, really well designed and really detailed, but you can even start small, like we were saying, and build towards that. So, really, just such an impressive talk. I'm so thankful that you had time to join us today and for us to learn more about it. And I have methodological things that I'm going to follow up with you about at a later time. I know you're very generous. If people wanted to email you, I'm sure you'd be willing to answer any future questions for anybody on the talk today. But really, just thank you again, and thank you everybody for joining us today. Really appreciate
Thank
it.
you so much. Really awesome questions. Thank you.
Hope you have a great day and enjoy the weather.
Bye.
Thanks.